Welcome. We'll be starting in about 5 minutes, or actually 3 minutes. If anyone has any questions or concerns, you can use chat right now. Once we get into the actual content, if you have content-related questions, we ask that you use the Q&A feature, But immediately for any technical concerns, you can use chat. Thank you. Welcome, everyone. My name is Mark Eisler with the NCCN Conferences and Meetings Department. I'll be in the background providing technical assistance to today's presenters and also the attendees, along with some other staff from the Conferences and Meetings Department. Throughout this webinar, in the very beginning, if you have any technical concerns, you can chat to us at the bottom of the screen. When we get into the content-related discussion, we ask that at the bottom of your screen you use the Q&A box to submit content-related questions throughout today's presentation. Also, on the nccn.org/policy page, nccn.org/policy, you'll see some additional resources that will be posted later today or tomorrow at the latest. There's actually one up there now, the ACS CAN has information up there that we've posted a PDF of the recommendations as well as slides of today's webinar. They'll go up later today or tomorrow. At this point, I'm going to introduce Alyssa Schatz from the NCCN Policy Group to welcome today's presentation and start.
Good morning, everyone. We will be beginning our day with a welcome from NCCN CEO, Dr. Robert Carlson.
Thank you. Hello and welcome to Elevating Cancer Equity, Recommendations to Reduce Racial Disparities in Access to Guideline Adherent Cancer Care. My name is Robert Carlson, and I have the privilege of being the CEO of the National Comprehensive Cancer Network. Have the next slide, please. The Elevating Cancer Equity Initiative is convened by the American Cancer Society Cancer Action Network, the National Comprehensive Cancer Network, and the National Minority Quality Forum. I would like to thank ACS-CAN and NMQF for their leadership and partnership on this project. This is an initiative that aligns with each of our organization's priorities, and we are pleased to be able to collaborate on this important issue. We would like to give thanks to our generous supporters and sponsors of this initiative who are listed here. Without their support, this initiative would not have been possible. Thank you. We also thank all of you for joining us as we explore actionable recommendations to advance quality, equitable cancer care. Here is our agenda for the day. Following my brief introduction, Lisa Lacasse of ACS-CAN will provide an overview of key points from a survey of patients, caregivers, and oncologists on their perceptions of and experiences with bias in care. And the remainder of the event features the Elevating Cancer Equity co-chairs, Dr. Robert Wynn and Ms. Shanta Chambers, providing an overview of the recommendations of the Elevating Cancer Equity Working Group. There will be time at the end for questions and answers. We start our discussion with some well-documented realities. Patients of color are less likely to receive optimal cancer care, even when adjusting for insurance status. Guideline adherent cancer care improves outcomes, including quality of life measures and overall survival. However, patients of color are much less likely to receive guideline adherent care than patients who are white. When people of color do receive guideline adherent care, the disparities in mortality are greatly diminished or vanish. There are multiple root causes of these disparities, only some of which are listed here. Note that the root causes of these disparities are not biological. Rather, they relate to biases and deficiencies in the cancer care system. As such, the convening organizations agreed that we must not only strive to better understand why these disparities occur, but more importantly, what actions can be taken to eliminate disparities. Thank you for joining us in this important conversation today. And at this point, I will turn the moderation over to Ms. Alyssa Schatz, Senior Director of Policy and Advocacy at NCCN.
Thank you very much, Dr. Carlson. And it's my pleasure to introduce to all of you Lisa Lacasse, who is the president of the American Cancer Society Cancer Action Network, and will be providing an overview of the highlights of the results of the Elevating Cancer Equity Survey today.
Hi, everyone. Thank you, Alyssa and Bob. And let me just go directly to our survey findings. Let me just note that on behalf of the three organizations, we actually asked a nationwide public opinion firm, quite a well-known firm named Public Opinion Strategies, to disseminate a survey to patients, their caregivers, and oncologists. And the objective was really to assess and evaluate perceptions of racial bias and discrimination in care. We know there are some facts out there, but we wanted to grab onto some of those perceptions. And I want to spend just a few minutes today highlighting, there's a lot of data, but highlighting some key findings and how those findings help inform the recommendations that you're going to hear later today. So next slide, please, Alyssa. So the methodology, just briefly, we surveyed 600 cancer patients and survivors, and you can see the breakdown there. And I wanted to note that we did oversample both African American and Hispanics. And then we also did a second survey of oncologists, and it's important to note that we were not able to oversample with oncologists due to the fact that there is a lack of minority representation in that workforce, which in and of itself is of issue. So again, the objectives were to look at assessing their perceptions, and we'll go through that. So let me go to some key findings. First, let me just do an overview of the cancer patients and caregivers. Next slide, Alyssa, thank you. So we wanted to find out have a much better sense of how cancer patients and their caregivers experience their interactions with their oncologists, their teams, and the actual care that they receive. And so in order to do that, the survey asked their patients and caregivers 14 specific care practices that we had identified as, if patients were receiving those individual care practices, then that would deem to be high quality care. And so here's what we found. Only 19% of patients and caregivers reported that their oncologist actually attended to all 14 of those high quality individual care interactions, and we'll see those in a moment. That African American and Hispanic patients experience a much higher level of negative situations than their white respondents. And another primary takeaway is that a significant majority of African American and Hispanic patients and their caregivers believe that there's racial bias occurring today in cancer care. For the oncologists, a few key findings there. One, that they result that racial bias is absolutely happening. The majority of oncologists address that. And you'll note some of the key statistics. And I'll just say, as the head of ACS CAN, we focus as a patient advocacy organization on sort of patient perspective and patient need, but we know how critical this oncology role is. And so it's really important to see and understand from a caregiver standpoint what their medical team is seeing and believing. And so these data are extraordinarily interesting and important. We also note that a majority of oncologists report that racial bias is happening often in our healthcare system. And even 4 of 10 say that they have unintentionally had racial bias in treating cancer patients of different racial or ethnic backgrounds. So there is a real awareness of this issue. Next slide. Now, as I mentioned, we'll go through, here are the 14 the care practices that we noted. Next slide, Alyssa. There may be a little bit of a delay. I'm not sure what people are seeing. And so there's, these slides are really full. There's a lot of data. So let me just, we tried to put a highlighter on a couple key points to make. But note that the green column are patients and survivors, the blue column are their caregivers, and then the purple column are their oncologists. I'm going to primarily focus on the green versus the purple. And again, these are the 14 individual care practices that we felt cancer patients should be receiving from their oncologists and their oncology teams. And there's some really stark differences in how patients and oncologists report behavior by their oncologist or their team that involve in seeking patient input. So 69% of patients report that their oncologist asked them what is best for them. So you'll see that sort of down the very first highlight, but only 47% of oncologists report doing so. Similarly, the next line, 65% of patients report that their oncologist asked them for their opinion about differing cancer treatments, but only 44% of oncologists report doing so. It's also concerning that only 39% of patients report that their oncologists tell them about available clinical trials. This was something we specifically wanted to ask about, and we'll again see some issues related to clinical trials specifically and some recommendations. So just it's interesting to note that there's quite a wide variance between how patients and survivors perceive these particular individual care practices versus their oncologists. Next slide is really around negative experiences and the percentage of patients and caregivers who say that they have experienced those negative experiences. And so nearly a third of all cancer patients report that they or a loved one experienced a situation where questions were not really answered in a way that they could easily understand them. And 25% report that they or a loved one felt their care team made assumptions about them because of their financial situation or circumstances. So again, this is like patients who are already, they've been diagnosed, they're interacting with their oncologists, and there are several, situations where vast majority or high percentages of patients are not getting what they need in that interaction. If we go to the next slide, you can see that nearly half of those that respond to experiencing at least one of these negative situations are are related to their ethnicity. So the left-hand side is sort of the overall data. The right-hand side is broken down by ethnicity. And it's just important to note that white patients and caregivers only report 1 of 7 of these 7 negative experiences 43% of the time. But you'll note that our minority respondents to this survey, African American and Hispanic, 63% and 67%. Huge disparity there in the way in which they perceive or they have experienced some sort of negative situation in their oncology and cancer care teams versus their white patient counterparts. Now, the last sort of set of data I want to talk a little bit about is racial bias. And so again, we're going to look at both subgroups, and if we can go to the next slide. So this is patients and caregivers are divided in their views about how the healthcare system treat people, whether they're being treated fairly or unfairly based on race. And you can see the question that was asked. And that for patients and caregivers, 47% noted that the healthcare system can treat people unfairly based on what their race or ethnic background is. And for oncologists, you can see often 54%. And what's interesting about this data is when we move a little bit further into the detail on the next slide. So again, down by ethnicity, we really see with patients and caregivers, this data is quite different. If you are African American or Hispanic, again, towards the right-hand side of the screen, where a significant majority of African American and Hispanic patients, 67 and 65% respectively, believe that the healthcare system treats them unfairly based upon their race. And this is just such a stark contrast and important as we develop these recommendations. The next slide really talks about sort of poor quality of care, and this is related to oncologists. And now that was patients and caregivers. Now this data is related to oncologists and sort of what they believe as it relates to whether non-white cancer patients are more likely than white cancer patients to receive poor quality care. And we wanted to break this down a little bit. We've got all oncologists, but by gender and then by age. And I would say that one of the things that is interesting about these data is that for those oncologists that are under age 40, so the newest of that workforce, see a very high percentage that are acknowledging that poor cancer care is of issue. And I think that that's something we really want to build on. So let me just go to the very final data before I hand it off back to Alyssa, and really note that all of this leads to health outcomes. And this final slide is really looking at whether oncologists believe that a majority of non-white cancer patients, based upon racial bias, et cetera, have worse outcomes. And you can see these statistics here. 62% of non-white cancer patients have the same, better, or worse health outcomes. 62% say that they are worse. And then you can see, lower statistics on worse, but for medical care and communication. So obviously all of these things wrap up to create the experience of non-white cancer patients. And as was noted at the beginning, these slides will be made available. I know it's a lot of data to go through in a really short period of time. So with that, I'm going to hand it back to Alyssa, and we're happy to take some questions at the end.
Thank you so much, Lisa. I'm now excited to welcome the co-chairs of the Elevating Cancer Equity Working Group, Ms. Shanta Chambers, who is the Executive Vice President for Health Equity and Community Engagement at the Patient Advocate Foundation, and Dr. Robert Wynn, who is the Director of the VCU Massey Cancer Center. And I will hand it over to them to provide an overview of the purpose and the recommendations of the Elevating Cancer Equity Working Group.
So thank you so much, Alyssa. And of course, this would not have been possible, not only without my wonderful co-chair, Dr. Nguyen, but also those individuals who worked tirelessly to come forward and form the recommendations that we're going to share with you today. So the purpose of the Elevating Cancer Equity Work Group was to discuss the root causes of racial disparities in access to guideline adherent cancer care and to uncover opportunities where discriminatory behaviors and bias in care delivery could be disrupted by developing policy and practice change recommendations that are actionable, but also when put into practice would result in meaningful change in patient outcome. So the work group reviewed a variety of materials in advance of meeting, and then we met for over 2 days and had to follow up with some subsequent phone calls to really flush out the recommendations that we are going to be sharing with you today. Next slide. As we begin to think about these recommendations, I ask each of you to really lean into the conversation today and really identify where there may be opportunities for alignment with your respective organizations. I would like to publicly thank and acknowledge the work of the 17 individuals represented here on this slide. They represented provider groups, patients, caregivers, researchers, and industry. And the composition of this group was intentional, wanting to make sure that we put patients and caregivers at the center and the core of the conversation, because as we saw in the data, their experience as it relates to their interface with the healthcare system is critically important. And we wanted to make sure that they played a vital role in bringing forth recommendations. So with that, I'll turn things over to Dr. Nguyen.
Good afternoon. And I just want to let you all know that it's been a pleasure to serve as co-chair with Shanta and also working with the ACS and the NCCN. I'm the Cancer Center Director at VCU Massey Cancer Center. And I'm going to talk to you a little bit about how we put things together. So next slide. Thank you. Cancer leaves a geographic footprint in our healthcare systems, that is no doubt. These data maps can help us understand where policies and clinical interventions will have the most impact in reducing patient risks. As such, we examined how to implement the following recommendations. We recognize that they will certainly need some tailoring to meet the needs of our community. But the reality is we believe that it was a good first step. Next slide. As the working group discussed practice changes recommendations to improve equitable care delivery, the conversation focused heavily on what implementation would look like and ultimately resulted in the development of what we're now calling an equity report card. Now, for many of you, we have numbers of report cards that are attached to our health systems, including around safety, quality measures, and these other things. This group really, I think, has stumbled upon something that we think may have high impact by really putting forward this health equity report card. Next slide. The equity report card is fully intended to serve as a tool for stakeholders that are interested in advancing equitable care delivery practices. Those stakeholders may include providers, payers, and accreditation entities. But really, this is, again, as we're sort of looking at this, a real big important first step. The report card itself includes 17 practices that the group agreed will have meaningful advancements in equitable care delivery. The practices have been divided into the following categories of community engagement, accessibility of care and social determinants of health, addressing bias in care delivery, and quality and comprehensiveness of care. Next slide. The first category the group identified as really high priority was the need for meaningful community engagement from the provider community. The recommendations to achieve this include, first, the provider incorporates meaningful community involvement in practice leadership through a community patient advisory committee or a designated board position. 2, the provider ensures all marketing and educational materials use messaging that is linguistically and culturally appropriate for the communities they serve. 3, the provider contracts with or has formal and equitable partnerships with community providers, community-based organizations, and/or faith-based organizations whenever that's deemed appropriate for community engagement and/or patient navigation. And lastly, that the provider demonstrates the results of community health needs assessments are used as a tool for program development through documented action plan tied to results. The community health needs assessments are required to be conducted by tax-exempt hospitals, but the results, honestly, don't always inform practice. This working group felt strongly that hospitals should demonstrate how they use the results of these assessments to inform program offerings and practice changes to meet, ultimately, community needs. Next slide. The group also discussed making more accessible and methods of addressing social determinants of health through care delivery. The recommendations to address this include ensuring that the provider facilitates access to government, commercial, or community-based non-emergency transportation services, or financial support for public transportation where available. Lack of transportation, we recognize, was a significant barrier to equitable care. An estimated 3.6 million Americans miss at least one medical visit each year because of the lack of transportation, with higher rates among those who are from racial ethnic minority groups. In many areas, there are government and nonprofit organizations offering transportation services and health providers, and we should build upon those relationships to ensure patients can access these services. The provider collects social determinants of health data and intake, and throughout the continuum of care, and then use it to guide patient care and population level management. We also think that the provider should also offer flexible hours for appointments, including evenings or weekends. The provider, we believe, also should offer culturally and linguistically representative patient navigators or community health workers through internal hiring or contracting with the community-based organizations. And patient navigators are emerging as a promising practice to reduce health disparities. We've known this, particularly in cancer care outcomes, and have been shown to be particularly effective at connecting to screening, diagnostic services, and many other things that are important. There was significant consensus among the group that connection to culturally and linguistically appropriate patient navigators and community health workers is a key strategy for advancing equitable cancer care. You'll see this reflected throughout several areas of both policy and practice change recommendations. And as we saw in the survey, rates of discussing clinical trials as a treatment option are far too low. Therefore, one of the practice recommendations is that providers ensure training is provided to staff on barriers to clinical trial participation, and that there are targeted efforts to reduce barriers to clinical trial participation through connection to appropriate services. Next slide. It's also critically important to acknowledge the real role that bias plays in care delivery. We know that non-white patients are less likely to get guideline adherent care, even when you account for insurance. Therefore, healthcare providers must consider mechanisms to address biases in care. The group's recommendations were as follows. 1, the provider embeds diversity, inclusion, and equity into practice, institution, or health system policies An example of that is recruitment, hiring, promotions, these types of deals. 2, the provider should adopt measures related to the recruitment, retention, and promotion of minority researchers and practitioners. 3, the provider uses health information technology to identify critical moments in shared decision-making and care planning when desperate care can occur. 4, that the provider incorporates disparities and equity frameworks into quality improvement activities. 5th, that the provider provides and requires annual implicit bias training for all of its employees. Next slide. The final category of our equity report card is ensuring the quality and comprehensiveness of care. This includes ensuring patients are referred appropriate preventive and supportive care services. Again, ensuring that all patients can be connected to navigators and requiring that clinical trials be discussed as an option with all patients. As we saw in the survey of patient caregivers and oncologists that we reviewed earlier, the connections to clinical trials is something most physicians are not even discussing with their patients. We feel that this is particularly important for patients who are people of color, who already we know have lower rates of representations on clinical trials, with Black patients representing only 3% of patients in recent oncology clinical trials, and Latino Latinx patients representing only 6%. We must do better. I'm going to turn it over to Shanta.
As I unmute myself. So to truly address racial disparities in cancer care, we must also pursue structural and systems change as well. I will now walk you through the working group's policy recommendations. Next slide. The working group developed a total of 16 policy change recommendations for action by Congress, payers including CMS, and other federal agencies. ACS CAN, NCCN, and NMQF will work to put the policy change recommendations into place through advocacy and outreach to Congress, CMS, and other federal agencies as relevant. We will also invite you, all of you, to help us in these efforts at the end of this presentation. Keep in mind that for every single social determinants of health, there is an underpinning policy that is either driving or reinforcing those social determinants. At this time, I'll walk you through the policy recommendations. Next slide. So the group identified 8 recommendations to the US Congress that will make meaningful progress towards equitable cancer care. And I understand that some of this may be a little difficult to read on the screen, but if you look at the chat, you'll see actually a link to the PDF of all of these recommendations. As noted earlier, Black and Hispanic patients are dramatically underrepresented in clinical trials. And we feel that the requirement that the FDA consider clinical trial diversity as an element of the drug approval process would help to improve efforts to increase representation in clinical trials. Additionally, there are racial disparities in access to HPV vaccine, which is a significant cancer prevention strategy. The working group recommends investing in public education efforts on HPV vaccine and ensuring that those campaigns are culturally and linguistically reflective of the community they serve. The same recommendation is also made for broader public awareness campaigns on cancer prevention, that they are more diverse, that they are inclusive, that they are culturally and linguistically reflected of the audience in which they're intending to reach. The working group also recommends investment in screening programs serving racial and ethnic minorities including the National Breast and Cervical Cancer Early Detection Program. Almost half of the people benefiting from the National Breast and Cervical Cancer programs are racial and ethnic minorities. Congress should also restore funds for the National Comprehensive Cancer Control Program that ensures funds are given to community-based organizations that are highly skilled at connecting with underserved and underrepresented communities for screening. We know that care outcomes are better when people of color are served by physicians of the same race. Unfortunately, only 2% of practicing oncologists are Black or African American, and only 6% are Hispanic or Latinx. Congress should invest in historically Black colleges and universities and other minority-serving institutions because they excel at training and education as well as care delivery. As discussed earlier, patient navigation is a promising practice to reduce inequities in access as well as quality. However, reimbursement for this service is severely lacking. Congress should pass legislation requiring coverage of culturally appropriate patient navigation across all payer systems. Finally, it's critical that we address basic infrastructure needs, including electricity, plumbing, water access, to ensure that all people have access to the resources needed for a healthy life. Congress should allocate funds to the Reconnect Loan Program and eliminate the current household threshold requirement that disenfranchises many rural communities. Next slide. So the group also felt it very important to develop some recommendations for payers, including CMS, and to advance cancer care. Payers should ensure that all patients, all meaning all patients, have access to appropriate genetic counseling and testing for individuals at high risk of cancer, as well as risk reduction services. Payers should also work to address barriers to clinical trial participation by covering related trial expenses. Finally, we noted in the equity report card for providers and that providers should be developing patient navigator services. But we recognize that for this to be sustainable, there must be appropriate reimbursement. Therefore, in addition to the recommendation that Congress pass legislation creating a billing mechanism for patient navigation service, that CMS and other payers should also reimburse through value-based payment models. We have some opportunities before us. The question is about us being provocative and ready to bring forth this level of sustainable change. Next slide. So one of the areas that the working group discussed at length is the importance of reforming our broken data collection systems. The federal government has 5 categories that are used for race: American Indian or Alaska Native, Asian, Black or African American, Native Hawaiian or Pacific Islander, and white. That's it. There are 2 categories for data on ethnicity: Hispanic or Latina, or not Hispanic or Latina. The working group feels strongly that this is a huge disservice to both the heterogeneous population within each of these categories and to the research process. For example, Native Hawaiians and Pacific Islanders together is offensive and inaccurate. The federal government should reform this system. The working group recommends that the Department of Health and Human Services should prioritize funding and resources for interdisciplinary research in the social determinants of health and health disparities research. HHS should require health systems to partner with community-based organizations to conduct research. Next, the CDC should really look at making HPV vaccine an opt-out instead of an opt-in vaccine. And lastly, Department of Labor should create a Department of Labor code specific for patient navigators. Next slide. Since the expansion of Medicaid, a number of studies have been published demonstrating greater access to screening and early detection of cancer in states where Medicaid has been expanded. Medicaid serves a diverse population, and the expansion of programs would significantly impact cancer outcomes for people of color. As such, the working group urges state governments to expand their Medicaid program if they have not done so. Next slide.
So thank you, Shanta. I want to actually reiterate on this last slide the importance of this particular group. The very first thing this group got together and they said, we don't want to do business the same way and essentially just have a bunch of text documents and not have it be implemented and executed in a way to have impact. And so I have to say that this group was one of the best groups I've ever worked with, because right from day one when we got together, the goal was to have something practical, pragmatic, that could be actionable. And I'm really proud to have been a part of this group and working as a co-chair with Shanta. So finally, I want to provide an overview of the working group recommendations to the clinical practice guideline developers. Next slide. The working group recommends that to address disparities in clinical practice guidelines should reflect the following. First, be reviewed for disparity issues within guidelines that could eliminate or reduce disparities. Additionally, clinical practice guidelines should incorporate language recognizing the existence of bias in care. Second, incorporate a framework to account for health disparities into the panel processes. Panels should also consider adding a health equity expert or representative, and we should also consider incorporating age adjustments on screening recommendations for specific populations that may have early manifestations. We believe that these recommendations are both practical, pragmatic, and actionable. I'll turn this back over to Shanta.
And so I know we've shared a lot with you. And so next we want to tell you the next steps in this process. So now that we've identified and published these recommendations, this is what's next. Next slide, please. So the next step is to widely publicize and disseminate these recommendations to targeted audiences of key decision makers and influencers. Upcoming event presentations at the NCCN annual conference and congressional briefings are also a part of those next steps. There will also be a publication that provides additional detail on the results of the survey that Lisa shared, as well as the working group recommendations. Most importantly, the convening organizations will be advocating for implementation of these policies and practice changes. We welcome your assistance and partnership in these important efforts. We cannot do this without each and every single individual that is participating in this webinar today. If you'd like to be involved, there will be a link to a form sent from the chat box today, and there will be a follow-up link email additionally with this link. Again, I encourage all of you to download the PDF of all of the recommendations that Dr. Nguyen and I have shared with you. I ask you to look at them through the lens of your organization and identify where those opportunities of alignment are within your organization and join us in this movement to really elevate cancer equity, because we want to turn the tide so that in 5 and 10 years, we're not having this same conversation. We will be coming forward with a new set of recommendations, really garnered up to address disparities in cancer care, looking to see different outcomes among those populations that are disproportionately impacted. So with that, that concludes our recommendations. And now I'm going to turn it back over to Alyssa for our question and answer.
Thank you so much, Shanta and Dr. Nguyen. That was wonderful. And we have a really engaged group here. We have a number of questions that have already come in. I'd like to remind people that if you would like to submit a question, please use the Q&A box. And we will do our best to address it. We have about almost 20 minutes, almost a little over 15 to take some questions and answers. So Dr. Nguyen, the first question is directed to you. Someone notes that in the survey, it's clear that there's a disconnect in communication between patients and physicians. What do you recommend for improving what they call bedside manner, or improving, better communication with patients?
Yeah, I mean, thank you for that question. And I think that there are a number of breakdowns in our sort of communication zone. It would be great also for Shanta to sort of chime in. Bottom line is, I think we've gotten away from the concept of bedside manner. Bedside manner isn't just being polite and being nice. Bedside manner is really making the person at the center of your clinic, the person in the center in your hospital bed, right? Understanding the knowledge as opposed to what we traditionally do is talking at patients as opposed to speaking with them. I think that there's a recall and a reawakening. And I would sort of say that given the fact that we're celebrating the 50th anniversary of the war on cancer, our next 50 years should include not just the development of new drugs, but the development of new communication strategies and skill sets that I don't think we always give to our young people who are actually trainees. So again, it's probably not as super sexy as having something with an RNA binding protein attached to it, and we're looking at it sort of that we're micro-targeting that. But I would say that basic blocking, tackling of communication skills, and even the content of how to communicate, is still a frontier that I think that we have not, as healthcare providers, completely fully embraced. But I think that as I move forward in the 21st century, it's something that we should be doing more of. And thank you for that question, because I do think we can all be better communicators. Shanta?
That actually, Dr. Nguyen, oh, sorry, go ahead, Shanta.
No, I was just going to say, I think we have to understand that communication is also a dual role for the patient and the caregiver as well. Think about, this person's just heard some of the most devastating news of their life, and we're expecting them to be able to observe, digest, and act all in one visit, realizing that that's not a reality. They are processing how this new diagnosis has to exist in the context of their everyday life. So communication can't be a one and done. It has to be one of those things that's occurring frequently, and it has to be occurring in a way that's easy for a patient to understand, creating that space for that patient to bring their full self into a visit and really be able to talk about it as partnerships in care. And how do we create a partnership that is most beneficial to me as a patient, because I'm the expert on me and you're an expert around the science. So it is this duality of our relationship that is most important for our health outcomes to be achieved. And we see in our data when that does not happen, that the outcomes that we desire are not always the good outcomes. They can be devastating.
And I also think, just to add to that, just real quickly, this concept of checking in. When we train medical students, when we train nurses, we're always sort of saying, let's check in, let's report, what do they know? We rarely do that when it actually comes to the people we take care of and provide care for. So it's funny to me that there's always been this disconnect that in education now we're demanding, and even sort of there are more demands right now on the doctors who train, the young doctors, or the nurses who are training nurses, on checking in and doing this. But it's interesting that same sort of standard isn't translated to our frequent check-ins with our patients and our, people and the families that we take and we provide care for. So if there's anything and any hope for me that there'll be an awakening that these check-ins are good for us, they should be good and put into practice what we do when we're taking care of other people.
Those are all important points. And, you know, they start to get to another question that was sent your way for both of you, asking about what kind of training should be incorporated into residency curriculums. And I think you've covered it a little bit, but how can we look at residency curriculums and medical school curriculums to incorporate more of a...
So I think we're going to have to reimagine the way we are training folks now. I'm going to speak specifically about clinical trials. It is interesting to me that in 50 years, we think we're going to have the next 50 years be different by doing the following. We want to teach, whether they're Black or tan or whomever, these people, these clinical researchers or clinical trialists, to essentially learn how to design good clinical trials and then implement them. Well, interestingly enough, that would be like training someone on the show Naked and Afraid. And so you give them some skill sets, you drop them in the middle of nowhere, and you say, hey, I want you to sort of improve minority enrollment on clinical trials without having any skills to do that. I actually think one of the biggest opportunities we have today is to reimagine how we're training our trainees. And so not only are we giving them, in this case, clinical trialists, examples of how to design clinical trials, which is important, how to implement and execute clinical trials, that too is important. But it's important to say that if we have a diverse workforce, and that diverse workforce is also armed with the skill set, working with Shanta and other groups, working with other mentors throughout the community about how to connect with, even understand that there are resources within that community that they can resource and leverage to actually get people to better understand, we might actually have a chance at a different outcome. So I actually think that that is not so out there and that we actually have the ability to do it. The first thing is to recognize that if we continue to do the same thing, we'll be back here 20 years later talking about the same doggone thing. And right now, I'm tired of seeing the same doggone thing. So let's just do something new. But I think it's this awakening around communication and the awareness that we are not as connected, or training our young people, particularly when they're coming out, or even older docs, the more seasoned docs like me, about what value the community has for them, and being able to connect with, leverage those resources to get more people, in this case, on clinical trial. That's my short answer.
That's such an important point, and it's something that was discussed at length in the working group. And Shanta, I wonder, I know that you led a lot of those conversations about community resources and engagement and really valuing the community. I wonder if you want to add to that at all.
That's exactly what I was going to say, right? We think about, and it extends beyond just a physician. So two things. My first would be, we require clinicians to do a clinical rotation, but we've never thought about them having to do some type of community engagement rotation, where they actually are interfacing with community organizations, learn how to engage with community organizations, have an understanding of what that really means. It's one thing to be in the community, it's something else to be in the community. And so I think we have to understand that healthcare has to exist outside of our institutions. It exists outside of the four walls of the health system. It exists in the context of the community. And you cannot separate those two things. You can't sift them out like flour. The other part is, we talk about this concept of multidisciplinary team, but no one has created a blueprint of how you actually operationalize it. You have nurses that are phenomenal, social workers that are phenomenal, nutritionists that are phenomenal. These are the individuals, the bedrocks that have that skill and training, and these other social determinants of health that are driving providers crazy because my patient can't do A, B, C, and D that I've recommended, without taking into consideration the social context in which that patient has to live. They don't live in those four walls of the health system. They live in communities.
Absolutely. I'm going to move us on for a moment. There's a question here about lung cancer screening guidelines and the impact that those screening guidelines, and this was also a discussion that was had by the working group, how screening guidelines that don't take age or race-specific data into account, how those might exacerbate disparities. Would either of you like to talk a little bit about that question, about how lung cancer screening guidelines or other screening guidelines might impact disparities?
the lung cancer and the colorectal cancer screening guidelines clearly would not have helped in this case, one of our Chadwick Boswick, right? The lung cancer or the colorectal screening guidelines we had for Natalie Reid would not have applied. We have now understanding, and what most people will talk about, well, they'll say things like, well, it's just an issue of access. I really don't care. The truth of the matter is I've been pushing this concept that your ZNA probably predicts more of your life expectancy and your health outcome than your DNA anyways. So that is your zip code or neighborhood of association. If you're in a zip code or neighborhood of association where you know that there's a 30-year decrease in life expectancy, and we actually go to that neighborhood and that community and recognize that there's increased rates of cancer, that should change the way we do screening. We tend to do one size fits all. And then we say, well, screening for lung cancer or prostate cancer, for example, really isn't all that useful because when you just screen everyone, there's really no benefit. But you never actually sort of say, how do you make it meaningful to a community? This is the era I am going to push, and there'll be pushback about the importance of small area analyses. And what those data, we talk about precision medicine on an individual level ad nauseum. And yet, we don't take into account the sort of precision medicine that actually would go along with community because we frequently say it's hard. And then we need bigger data sets because it's unstable. The reality is the community is calling for not, your stability of the data. They want to know what data you're collecting and what are you going to do with it. In fact, I think over time it erodes trust. I'm just being real, y'all. This is probably why, I don't get invited to these things, but I'm just being real that many people are now sort of saying to you, you're collecting all this data, but how is it impacting me? We don't even get the data disseminated about us or our communities. We all have to up and level up our game. So when it comes to screening, there certainly are, I'm not going to sort of make blanket statement that we should modify, make blanket. It's still I call it the hammer approach. Right? We say, oh my God, it turns out that we're having younger, more deaths from African-American women and men and related to lung cancer. Well, instead of changing the guideline to 55, we should maybe change that to 45. Yeah, that's a start, but it's still a brick on cell type approach. If we're talking about precision, even on a single cell, it's amazing to me that we could talk about precision on the level of a human being's single cell, and we're comfortable with that discussion, but we have yet to be comfortable with how we're going to be more precise around community data. So I think that's a challenge of the 21st century. That's a long-winded way of sort of saying, yes, I think that even screening programs should be broad, but within that broad context, we should be much more reasonable in recognizing that there may be subsets and that those subsets may need some tweaking.
So it's about translating that. Sorry, go ahead.
And Alyssa, I would just briefly add, keeping in mind with the current lung cancer screening, that we have to ask ourselves, who is it excluding? And so we're not allowing room to account for the genetic factor for Asian women, right? So we have to ask ourselves, who are we excluding? So if you're someone who has never smoked, you're excluded from the current guidelines. So I think there are a lot of things that we also have to ask ourselves, who are we excluding? And we know that there are genetic factors that make some populations at greater risk for some things than others, but we're not always taking that into consideration. So I think we have to ask ourselves, who are we excluding?
And Shanta, this is why I love doing this with you. And it also brings to bear that, what if you live next to a highway and you have diesel fuel exposure? We know that your environment is going to increase your risk. That's not taken into account.
Yes.
So what I'm saying is we do this whole one thing that one size fits all, and then we get disappointed when we get the screening rates, not understanding that we just have to be more smart and precise with the screening. How many of these at-risk communities are living next to dumps or things like that where they have more environmental exposures? And so then we scratch our head and say, oh, well, we don't really know. I don't think that this is a time to actually lose courage. I think this is a time to gain courage and take some risk at coming up with some data ways of approaching these data and how we can be better serving the people we say we want to. So long-winded way of saying, I think we got screening, I think is the hot next frontier. I'm going to be stirring up the pot because I think the way we're doing it is okay, but we can do better.
And I'm hearing translating precision medicine into precision screening. And I'm hearing keeping at the front of our minds who we are leaving out in these conversations, who we're excluding. That's great. So We have 4 minutes left, and I want to maybe do a lightning round because there are 3 questions that have come in that have a lot of overlap that I'd like us to address. And Lisa and Bob, at the end, there's one that I think applies to both of you as well. The first question, yes.
Alyssa, I'm so sorry.
No, it's okay.
Thomas would probably choke me if I don't add this. We talked about it in the context of screening, but I also think we have to be critically sensitive for those cancers for which there is no screening mechanism at this current time as well.
Yes.
So we have to make sure that we have some different conversations. All
yes. Right. Good point. So the first question, lightning round, is around clinical trials. We've gotten, I don't know, maybe a dozen people asking about this related to clinical trials. We've talked a lot about the structural and systemic barriers. There's a lot of conversation around how do we address the understandable and very appropriate mistrust due to both historic and current injustices that have and do occur with clinical trials. And I know that's not a great lightning round question, but any thoughts on that?
The quick thing is we're going to have to rebuild trust, rightfully so. You know, the reality is what President Nixon one time during Watergate said, just because he's paranoid doesn't mean that people weren't after him. The truth of the matter is there is real reason for many at-risk communities, including rural communities, to actually be distrusting of us. So the reality is, in a lightning round, we are going to have to rebuild trust brick by brick, and it's going to take time. And it's not going to be just one event where you magically wave a wand and then the community forgives you. We're going to have to show up and show out on a consistent basis, and I'm going to add to it longer than the length of a grant.
Well said. Okay, Shanta, I'm going to pick, sorry, go ahead.
Oh, I was going to say acknowledge and affirm. So we have to acknowledge that these things happen, affirm individuals' lived experience, and appreciate emotional intelligence. We have a complete disregard for emotional intelligence, and so communities have emotional ties to these experiences.
Very good point, and just like a social worker, Shanta, and I agree with you on that as a fellow social worker. Last question is around how do we know that we really moved the needle? And Shanta, that I know that you've talked a lot about that. How are we making sure that we've actually made change? And then for Lisa and for Bob, how are NCCN and ACS CAN going to actually hold ourselves accountable and make sure that we do work on moving this needle? So Shanta, I'll kick it over to you first.
And so I think that is also one of those next steps in this process for us to really come back. We talked about this in our work groups in terms of what are going to be those benchmarks. So we still have some work to come back to and actually identify what are the performance measures by which we want to measure our progress again. So that also gives us another next step in this process to say, hey, what are going to be those tangible benchmarks?
And Alyssa, I'm just going to jump in and echo what Dr. Nguyen noted, which is we can't keep doing the same thing over and over and over again and expect different results. We have to talk about this differently at the policy level to our lawmakers. You know, I'm a policy person, so I'll focus on those stakeholders, but we have got to make people understand that we have to change things foundationally if we want this to be different. And that's going to be really the way in which we'll know whether we're making change or not, is whether we're actually doing things differently, as opposed to just talking about the problem, focusing on making change to get to new solutions. That's going to be the best measure.
Great. Bob, do you have any remarks or thoughts?
Well, I think that the part of what really excites me about this working group and the work product that's come out of it is what both Shanta and Dr. Nguyen commented on, and that is that we're looking for things that are actionable. We don't want to talk. Talking is important, but we want to do. And, you know, sort of, we want to move the needle. And one of the really wonderful things about the recommendations that have come out of this working group is that there are actionable items that are measurable, so that we can implement them. And it's going to take a huge effort to do that. But we can implement them, we can measure them, we can feed back to people what they're doing and so forth. You know, I don't think I've ever met a physician in my life who wanted to provide bad care. And we need to realize that people really want to do better. They want to learn, they want to do better, and so forth. And you know, the survey showed us that it's obvious that many physicians don't know how to do better. They realize that they're not doing optimal care, culturally sensitive, appropriate care, but we need to give them the tools and the metrics that will allow them to actually improve their care, improve their bedside manner, and build trust, and that will build trust. You know, trust is something that's very easy to lose. It's very hard to regain, and it's going to take time. But it's got to be actionable. It's got to be based upon action, not just words.
Absolutely. Well, I know we've gone a little bit over time. I want to thank everyone for being here today. We really appreciate your time, and we look forward to working with you as we try to, as Bob said, put these actionable recommendations into practice. I especially, before we end, I just want to thank Dr. Nguyen and Shanta for being our fearless leaders, for sharing your time. This has been an enormous amount of your time and your talent, and we appreciate that, as well as the time and talent of all of our working group members who really invested an incredible amount in this effort. I also want to thank all of the leadership and staff at ACS CAN, NCCN, and NMQF who have made this possible, the meetings department for their support today, and of course, I again want to thank our supporters of this initiative who have really made this entire initiative possible. So thank you all again for attending today, and this is the beginning, not the end, and we look forward to working with you all to make sure that we're held accountable and really do move the needle. Thank you.